Hello, everyone, and welcome to today's webinar hosted by the Oregon Office of Rural Health. I'm Rhonda Ann Gerst, the Rural Health Clinic Program Manager. The webinar you are attending is titled 2021 E&M CPT Coding and Billing Changes, presented by Kim Huey of KGG Coding and Reimbursement and Consulting. Kim Huey is an independent coding and reimbursement consultant providing audits, training, and oversight of professional coding. She completed 3 years of pre-medical education at the University of Alabama before she decided that she preferred the business side of medicine. She completed a Bachelor of Science in Healthcare Management from the University of Alabama and a Master of Jurisprudence in Health Law from Loyola University Chicago School of Law. Ms. Huey has multiple certifications in coding and compliance through the American Academy of Professional Coders, American Health Information Management Association, and the Healthcare Compliance Association. Kim is the co-author of AHIMA's Procedural Coding and Reimbursement for Physician Services 2020. And there is much more to her bio. Please take time to review it. I did shorten it up this time. I have a few housekeeping details. This webinar will be recorded. The webinar and slides will be posted on the Oregon Office of Rural Health website on Monday. Eric Jordan is our tech support today. So if you have any problems, you can type into the chat box. If you have, let's see, you are all currently muted and your video is off. There will be time for Kim to answer questions, so you can enter your questions in the chat box. I will be happy to read those questions. Kim, will you answer questions throughout or at the end of the webinar?
Well, I think it might be best if we stop a couple of times, and then we'll do most of them at the end, but I'll stop a couple of times if there's specific questions to that section. So,
okay, perfect.
Okay.
Perfect. Okay.
Okay.
Let's see. At the end of the webinar, I will put a link to a survey in the chat box. Please take a minute to complete that survey. At this time, I would like to present Kim Huey, also known as Kim the Coder.
Okay. Thanks, Rhonda Ann, and thanks everyone for joining us today as we're getting ready for 2021. You know, things kind of just rush up on you at the end. I started looking at these code changes 2 years ago when the AMA and CMS first began to talk about them. And then a year ago, we had the basics of it. And then 6 months ago, I started teaching it. And now, wow, it's just a couple of weeks till we actually put these into place. So we're going to walk through the new guidelines, a little bit of the background of why we have these new guidelines, and then some examples of how we're going to implement them. And as we just decided, we're going to stop a couple of times and ask questions. And I'm also happy to answer questions at the end. You'll also have a contact for any follow-up questions. And any follow-up questions I get after the webinar, I will, of course, copy Rhonda Ann on them so it can be, shared with everyone. Okay, so first of all, it's just our office visit coding that is changing. Anywhere you would code 99202 through 99215, that's what's changing. Any of your other billing and coding rules, those are not changing. It is just how you determine the level of service. So we're going to code our visits based either on time or medical decision making. I'm going to walk you through both of those options. 99201 has been deleted, and if you are familiar with those, that's the first level of new patient office visit. It was deleted for a couple of reasons. One is that if we're going to code based on decision making, 99201 and 99202 have the same decision making. So you didn't need two codes with the same definition. The other reason, and this is how the AMA co-chair of this committee that came up with this put it, once a physician or nurse practitioner, physician assistant walks in the room with a patient, you have a level 2. You don't have a level 1. We're still going to do a medically appropriate history and examination. Now, it's not going to affect our coding. We're not going to be limited by whatever level of history and exam it is, but you're going to do what's necessary for clinical reasons, for medical legal reasons, for continuity of care. All those other reasons to do a history exam, that's why you're going to do it. It's just not going to support your coding. Now, we're going to have a new code for prolonged services of 15 to 30 minutes. So if you're in a scenario where you are coding for prolonged services, then you may use that. We won't use that for Medicare, of course, but we might use that for other payers. Again, one more time, there is no change to any other evaluation management code. Whether we're talking preventive medicine or we're talking hospital care, we're talking nursing facility, none of that is changing yet. I will tell you that there is, it works, they're already working on it, changes to any code set that is based on history, exam, and decision making. Those are all being revised. They may or may not be ready in 2022, it may be 2023 or even after, because they're really breaking them down to the very basics and building them from the ground up. They've also felt like they can't just take the office visit principles and take them to other sites of service, because really the nature of care that we're rendering in the hospital or in the nursing facility is going to be different. So again, this is just those instances where you would be billing office visit codes. The basis of how you do that is changing. So I'm not going to go into a lot of detail about how we got there. Just to remind you, we've had the same coding system for 28 years now, since 1992. And if you think about how medicine has changed since then, we went from paper records to electronic records. We've ended up with a lot of different things thrown in that medical record, and we ended up with what they're calling note bloat. And you've seen these huge notes that you really couldn't tell what was going on with a patient. So that's what we're trying to do. We're trying to get back to the basics of, hey, what's going on with this patient? And to really reinforce that medical decision making and the real cognitive work of the visit. Again, this is really just as a reference for you. These were the principles that the AMA put into place when they decided, yes, we need to change the office visit coding guidelines. And so it says the CPT, the RUC work group. And if you're not familiar with that, the RUC is the Relative Value Update Committee. They're an arm of the AMA, so to speak, and they work with the panel to come up with values of a particular code, new codes and the existing codes as well. And then they suggest those values to CMS. Most of the time CMS takes them. Sometimes they lower them or they may make other changes. So this was their principles. They wanted to decrease the administrative burden because they really want to code the way physicians and other qualified healthcare professionals think. And you may see that term if you're looking at the CPT definition, qualified healthcare professional, QHP, that's a nurse practitioner, physician assistant, nurse midwife, someone of that level who can also perform and bill for office visits. They wanted to decrease the need for audits by looking at more detail in the CPT codes. They wanted to decrease the unnecessary documentation that's really not needed for patient care, and to do that promote higher levels of medical decision making. They also really wanted to make sure that we were resource-based, meaning we could really show the value of each visit compared to other visits, and then we're not really just shifting money between specialties there. So that was their plan, that was their purpose. Again, they're starting with office and other outpatient codes, anywhere you would bill those codes, and eventually going to include all levels of evaluation and management. And so this is a chart that you might find in the CPT book and some other publications. This just reminds us that, again, office and other outpatient is what's changing. Other E&M services, they're going to continue as they are now, history, exam, and medical decision making. So they did change time, and they did change the medical decision making, and that's what I'm going to walk you through today. So time, when we're coding an office visit based on time, right now we can code that based on time only if the visit's dominated by counseling and only the face-to-face time counts. Now, during this public health emergency, telehealth visits were allowed to be coded on time, even if it wasn't counseling, but that was really just the only provision there. In 2021, our office visits can be coded on time, even if they're not dominated by counseling. And the time is not just face-to-face. That's the big thing. It's not just the face-to-face time that counts. And of course, we always have the other option of a new revised medical decision-making criteria. And so let's just be clear right now. It can be either or, whichever supports the higher level of service, that physician, that provider. So if time is a higher level, we can code by time. If medical decision-making is higher, we can code by medical decision-making. You don't have to decide up front. It can vary visit by visit, patient by patient, whatever is appropriate. I will tell you, though, that the AMA has expressed that most providers, most physicians are going to code higher based on medical decision making. That time is only going to be important for those physicians who spend a lot of time in a particular visit. And so, again, whichever yields the higher level of service is how you're going to code these. Now, we said it's not just face-to-face time for time. And so these are all of the things that count. These are listed in your CPT book, but things like preparing to see the patient, reviewing tests before you see the patient, getting a separately obtained history. Maybe you had to call someone else to get history on that patient. That medically appropriate exam, counseling and educating the patient, the family, the caregiver, ordering medications, tests, and procedures. Now, again, let's remind ourselves, this is just physician time. If someone else, clinical staff, is doing some of these services, they can't count toward the time for the visit. It just doesn't count. It's just physician time, nurse practitioner, PA. It's just the provider time that counts. Now, when we discuss this, I just kind of want to throw this out there, that if you've got a great workflow and you've got a nurse or medical assistant or someone doing the orders and ordering the tests, the procedures, there's no really need to change that just so that you can count that time. It's probably not going to be beneficial to do that. But again, it's just the physician provider time. Referring and communicating with other healthcare professionals. And when it says without separately reported, what that's referring to is that there is a set of codes for interprofessional consultation. And they've got some limitations and they may not be that widely used, but the point they're making is you can't count that work in both codes. So if you're billing the interprofessional consultation codes, then you can't count that work towards your office visit. Documentation will count. So documenting clinical information in the record. Now, only if it's done on the date of service, okay? So if you're doing documentation later, that time is not going to count towards your visit. Independently interpreting results. And so that would mean if you are actually interpreting a test that was billed by someone else. So maybe that patient provides x-rays that were taken somewhere else, and you actually look at the images and you document your own interpretation, but you're not billing for that. Then that time will count towards your office visit level. Also, care coordination, as long as you're not separately billing a care management code for that same time. So we can't get paid twice for the same snippet of work or the snippet of time. So these are all the things that count. Again, you see it's not just face-to-face, but it is on the date of the visit, and then you can count that total time and choose your visit level. So here are the times for 2021. You can see they're a little different than what we have for 2020. First of all, of course, you see 99201 is gone. 99211 is not specified. That's that nurse visit. And I know in your rural health clinic setting, there are limitations to you using that. That is a nurse visit, however, and it's not changed. If you use it now, you can use it. If you don't use it now, then you won't use it. You've got your visit levels and the various times. Notice that there's a time range for each. And so just as an example, right now in 2020, 99214 requires 25 minutes face-to-face with a patient, more than half of which was counseling. In next year, 99214 will be 30 to 39 minutes, but it's everything you did and not just your face-to-face time. So the time values are higher, but you do get to count a lot more things. So it probably balances out. Clinical staff time does not count. I know I've already said that, but I wanted it really clear on the slide. And then that bottom bullet, only one person per minute. And that's how the AMA described it, but to make sure that we understand what we mean here. So if both the nurse practitioner, physician assistant, another provider, and the physician saw the patient the same day, we can combine their time to get to a higher level of service. What we cannot do is combine the time if they're both in the room with the patient at the same time. So basically a minute counts once. You can't count 2 minutes, even though it's two different people there. So for example, nurse practitioner sees the patient for 20 minutes, feels like it's something the physician needs to step in on. The physician comes in and sees the patient for, let's say, another 20 minutes. 20 plus 20 is 40. That would support the higher level. However, if any of that time was overlapped, if they were both in the room at the same time, then you couldn't double count that. It would reduce the overall minutes because you can only count a minute once, not twice, even though there's two providers. We do have prolonged services code as well for those times when we exceed the value of that total time for that visit. So once we reach a level 5, if we go beyond that level 5, then we can add on these prolonged services codes. And so we've got a chart from the AMA that kind of helps us with that. So basically, up to 75 minutes or less than 75 minutes, it's going to be level 5. Once we reach that 75-minute mark, it's 99205 and 99417. And then for each additional 15 minutes. And I don't think these visits are going to be usual, but it is a way to be compensated for those extra long visits there. Now, there is a difference of opinion between the AMA and CMS on time, and I'm just going to share it with you. It may not affect you at all in your RHC setting there, but the AMA defines time as from the lower level of the time range, and I'll show you that again in a minute. CMS says no, in order to add that prolonged services code, you have to get to the higher level in that range. So I'm going to go back a slide just to make that clear. So for example, the AMA says if you are billing for prolonged services, it would be that level 5 plus 15 minutes. Then you would hit the new bucket of time, basically. So 99205, 60 minutes plus 15 is 75. CMS says, nope, to get to that higher level, to bill that out on code, you have to meet the highest number in that range and then go 15 minutes beyond that. So the CMS would say 74 plus 15 is 89. And just that difference there in that range. Again, I don't know that that's going to be relevant for you with the prolonged services, but it perhaps would be with some of your payers other than Medicare. For other than Medicare, I would use this chart here that's in the AMA and the CPT book. You also have some current prolonged services codes, and just to remind you, we've had these for years, but they were for 30 minutes. When we needed a new prolonged services code, they decided to do 15, kind of that lower limit there. So you will not use these current prolonged services codes on office visits. You could use them with psychotherapy, with consultations, home visits, domiciliary, and care planning for cognitive impairment. Now, I just kind of want to point something out, consultations. Of course, Medicare does not pay consultation codes. Some of the other payers do. And if you ever bill consultation codes, just a reminder, those rules are not changing for 2021. Just the office visit codes, anywhere you'd use those codes. You have a couple of codes for non-face-to-face. I mentioned them. In your setting, especially when you're billing Medicare, you won't use these because your setting, of course, requires a face-to-face with a patient. But there is a provision for prolonged E&M service when you're not face-to-face with a patient. So reviewing records or that kind of thing on another date of service. We've got the code and most payers don't recognize it, and it doesn't fit in with your billing model there. So it's included for completeness, but I don't think it's going to affect your coding. Okay, so you've got the time. You're either going to code by time or this new medical decision making. When you're coding by time, of course, time has to be documented. And we don't have any guidance yet on how to document time. So I'm going to give you my opinion. And my opinion is based on 35 years in healthcare and working with compliance and with defending physicians when they're audited, that kind of thing. So my opinion on the time is I don't think time in and time out or clock time is going to be required. I think for a lower level of service, just your total time, just 30 minutes spending care of this patient today to include face-to-face visit and review of records, something like that. I think, however, if you're going to have a longer time and you're going to be adding on this prolonged services code, that's when you might want to be a little more detailed about what you're going to need to document for time. So again, you've got your time, the physician, the provider is going to document 30 minutes spent in total care of this patient today. That's going to support your code. Now, that's the time, but remember I said the AMA said really they don't expect physicians to use this unless we have some really extended visits. For the most part, they do expect physicians to code based on this new medical decision-making table. Now, I know this slide may be small, may be hard to read, but I do have a link for you at the end where you can download this directly from the AMA website. Also, with that link is a link to a 16-page document from the AMA that defines some of the terms that they use in the grid. So I would suggest you download them. I'm going to go over a lot of those terms and a lot of the nuances here, but it would still be a great resource for you to have that AMA document there. But again, this is your grid. I've had people asking me, hey, Kim, we need a cheat sheet. Well, this is it. This is what you need for that coding. Okay, so let's walk through this. We're going to show you how this works, and then I've got several examples of, maybe common scenarios you might see in the clinic and help code those. First of all, the first thing to note is that this is a 2 out of 3 situation. We have 3 different elements of medical decision making, and your visit is going to be based on whatever level is supported in 2 of those 3 elements. It's not 3 out of 3, it's 2 out of 3. And that is true whether it is a new patient or an established patient. Well, that's a change. You know, right now we have different criteria for new patients than we do established. Next year, it's not. It is just, 2 out of 3. It is a new or established. So a level 3 is a level 3, whether it's a new patient or an established patient. The new versus established patient definition did not change. Remember, that is a new patient is one who has not received a face-to-face professional service from that provider or another provider of the same specialty in the same group practice in the past 3 years. That definition is not changing, but I think this makes it a lot easier. If you're familiar with this now, you may realize we've got kind of this offset. A level 3 new patient looks more like a level 4 established patient. Nope, next year it's going to be a level 3 is a level 3 is a level 3 there. So that's going to be easier to deal with in terms of crosswalks and looking at that. So I like that. That's a change that I think is going to be for the good. So our elements are number and complexity of problems addressed. Again, going to go into some detail on that. Amount and or complexity of data to be reviewed and analyzed. And then risk of complications and or morbidity or mortality of patient management. Again, going to walk through each of these and give you maybe some things to look for, some tips, some hints, definitions to help you deal with this. So first of all, 99211, not applicable. Again, that's that nurse visit, may not require the presence of a physician. None of the rules regarding that are changing. If you code it now, you'll code it next year, same way. 99202, 99212 is straightforward. 203213 is low. 204214 is moderate. 205215 is high. So let's look at each column here. So first of all, number and complexity of problems addressed. I bolded it, I italicized it, I highlighted it, whatever I can do to make sure that word comes through, because that's the key. In order to spread it in the category, the problem has to be addressed. The physician, the provider has to document what they did with that problem. Now, it can be managing it. It can be ordering a prescription. It can be ordering diagnostic studies. It can be discussing a treatment with the patient, even if they ultimately decline, but it is addressing that problem. Just listing a problem without saying what was done about it doesn't count. So we've got to be able to link that and see. Now, the fear that I have, or what I have seen with some of my clients that I work with, is that the physicians may lump all of those diagnoses, they'll list the diagnoses, but they'll lump all of the orders under one diagnosis. And then we can't tell if the others were addressed. So I've got to be able to tell what was addressed, what was done for each problem there. Now, the other point is, if it is a problem that maybe you're not the treating physician, but it's managed by somebody else, but it does affect what you're doing, then that counts as addressing it, but you've got to show how that works. So again, the notation that it's managed by somebody else doesn't qualify unless you're doing some kind of work or you're indicating how it affects your treatment. So let's say, for example, the patient sees endocrinology for diabetes, but they're coming to see you for a joint injection. Well, we know that a steroid injected could cause a patient's blood sugar to go up. And so you say, I'm not managing diabetes, but how it may affect how this joint injection works. You may have to watch your blood sugar for a few days, that kind of thing. So it's not what you're treating, but it affects what you are treating. That counts as addressing the problem. So again, just make sure it's clear you did something with that problem. So just walking through each of those blocks there. So 202212, a minimum, which is a self-limited or minor problem. Now, Rhonda Ann told you I'm from Alabama. Obviously, I'm a Southern girl. And I've always defined this as you should have called your mama instead of going to the doctor, okay? And so it's funny, a couple of weeks ago at the AMA conference, the physician presenting this, who is not from the South, said, you should have called your mother, gotten chicken soup and ice cream. So really the same idea. And you may not have a lot of this. You may not see a lot of patients that really, they didn't need to come in. 203213 is low. 2 or more self-limited or minor problem, or 1 stable chronic illness, or 1 acute uncomplicated illness or injury. Now, I want to come back to the acute uncomplicated in a minute in relation to something else, but let me make a point about stable. So the AMA does define the fact if a patient is not at treatment goal, they're not stable. So this patient may have a chronic condition and they're doing great for them, but it's not where you want them to be. I reviewed a note the other day and it said that the patient was doing great, doing much better. Their blood sugar was 200 and their A1C was the best it's been. But it's not where we want them to be. It's not normal. And so I wouldn't call that stable. That would still be with an exacerbation or progression because it's not at treatment goal. So kind of keep that in mind. Moving on to moderate, and I will come back to that acute uncomplicated. I want to make a point there. So under moderate, 204214, one or more chronic illnesses with exacerbation, progression, or side effects of treatment, two or more stable chronic illnesses, an undiagnosed new problem with uncertain prognosis, an acute illness with systemic symptoms, or an acute complicated injury. Okay, so most of these are kind of self-explanatory. I do want to make a distinction, and the AMA makes this distinction between an acute illness with systemic symptoms and an acute uncomplicated illness. And so someone looking at this table, looking at this grid without reviewing the AMA guidelines would go, that patient has a flu, they've got some body aches, that's systemic symptoms, that's a 4. Well, the AMA does make the distinction if someone has those systemic symptoms, but it's really in a minor illness and we're going to control the symptoms, it's really something that's not really worrisome, then that's going to be acute uncomplicated illness and not acute illness with systemic symptoms. So kind of think about that, balance that. That's where every ear infection does not become a 4. So again, is it an acute uncomplicated illness and they're running a fever, but that's not really the focus of what we're doing? Then think about that. That's more of a low than a moderate there. And then under high, one or more chronic illness with severe exacerbation, progression, or side effects of treatment, or an acute or chronic illness or injury that poses a threat to life or bodily function. So we have that distinction there. Now, a couple of things the AMA points out there. Severe exacerbation is how the physician defines it. So if in your opinion today, this patient is having a severe exacerbation, then paint that picture. Tell that story about that patient to show that it is that severe exacerbation. They also make the point about acute or chronic illness or injury that poses a threat to life or bodily function. They go on to say that's in the near term without treatment. So, for example, a patient with cancer, it's all that potential threat to bodily function. But is it a threat like right now in the near term if we don't have any treatment? Or is it something that they're doing pretty well, they're pretty well maintained, they're pretty well controlled? So again, that distinction there between the moderate and high. So at this point, I've talked about time, I've laid out medical decision making, we've started talking about the problems addressed. So I will pause right now and see if we've got any questions we wanted to address before we went to the rest of the chart there.
Yes, we do have a question, Kim. What have you heard about CMS's statement about start and stop time for prolonged service codes? To review, other payers also have that language. Is that start and stop time of the total time of the E&M and then the prolonged service?
If you're good, for those that are required, and I know CMS is requiring that on the hospital side, they have still not said specifically what they're going to require with this new office visit coding. So I kind of expect to see something from the various contractors about regarding that. But yeah, any payer that says they want to see start and stop times when you're using prolonged services, they're going to want to see the whole thing because that's how we support the prolonged services. So if it's a payer that requires start and stop, then I would look at doing that. And again, for the whole period of time. But I would also expect to see guidance about these new office visit codes coming out. And the guidance we previously had, I wouldn't necessarily go with that. I just really expect we're going to see further guidance on the new scenario here.
Okay, that's all I have for right now. Oh, hold on. I have another one. Is G2212 for Medicare and 99417 for all other payers?
Correct. Yeah, and unless you have a payer that says, hey, we prefer to follow CMS, because they do have that option. But yes, G2212 is for CMS for Medicare. 99417 is for all other payers. Do remember the slight definition though. Remember 99417 starts at the lower end of the time value. G2212 starts at the higher end of that level 5 time value. But yeah, you've got it correct.
That's all there is for right now.
Okay, well, let's we talked about number and complexity of problems addressed. Let's look at this. Oh, okay.
One more. What about G2211?
That is not really relevant in determining the office visit code level. I didn't include it in the presentation. We can talk about it a little bit at the end if you like. That is that new code that's going to be added on to Medicare claims when you're either the primary care physician or you are a physician caring for kind of long-term care of a complex chronic condition. So Medicare does expect that to be added on to 90 to 100% of office visit codes for primary care and a significant percent of other specialists like endocrinology, rheumatology, that kind of thing. It's not limited to specialty. It is really the nature of the care. And again, it's not included in this presentation because this was office visit levels, but I'm calling that kind of building relationships with patients. Because if you review the CMS documentation on that from the final rule last week, they really talk about we want to compensate physicians for that, building those relationships for that ongoing care to enhance care of chronic conditions. So hopefully that helped.
Okay, thanks.
Okay, amount and or complexity of data is our second element. And again, it's 2 out of 3. This is the second element. And honestly, this is the one that I had a little more trouble with. It's got more moving parts, but hopefully I can break it down and help you with it a little bit. So first of all, one of the things I really liked about this is the fact that you get separate credit for each unique test or each unique source of external records. So if you're familiar with this right now, you get credit for lab. Doesn't matter how many labs, 1 lab, 14 labs, it's the same credit. Same thing with radiology. You might have x-rays and MRIs and CTs, but it just counts as radiology. Next year, you will get credit for order or review of each unique test. And they're defining unique test as identified by a separate CPT code. Okay. Same thing with external notes. If you're reviewing records from another provider, right now, it doesn't matter how many different records, it's just review of records. Next year, it's each unique source. Okay, so that's the good thing about this. Now, and we've known that all along, but a couple of weeks ago, the AMA kind of came out and gave us some enhanced guidelines, and they said you do not get credit for any of these if you're billing for the test. You either get credit for billing for the test or you get credit for in the data. So if you are billing for that test code, then you won't get the data points there. Now, that said, again, I've been teaching this since June. I developed about 30 different examples for this. And so when the AMA came out with this different way to look at this, I thought, oh no, I've got to redo all my examples. But I went through all 30 of them and it did not change the level of service in any one of them. So data is not usually going to be one of your 2 out of 3. It could be, but it's not necessarily going to be your 2 out of 3 there. So that said, kind of laid that out. I think what makes this a little more complicated to look at is the category idea. So let me walk you through that, and then I'll stop and take questions if we need to. So 202.212, straightforward, no data. 203.213 is low decision-making, low complexity of data. It's limited data. And you have 2 categories in this level. Category 1 is tests and documents. So that's a combination of any 2 of review of prior external notes, review of results of test, order of each unique test. And again, we're not counting the test if we're billing for the test. Okay. So that's category 1. You need 2 things to count category 1. And that could be 2 external notes. It could be 2 lab tests. It could be 1 external note, 1 lab test, whatever, 2 in that category. Or you could meet it in category 2. Now again, category 1 or category 2, you don't have to have both. Category 2 is assessment requiring an independent historian. So anytime you get the history from somebody else, that patient has dementia, you get that history from the daughter. I looked at a note the other day where the patient was at the doctor's office and he couldn't remember any of his dates, so they called his wife and got his history from his wife. That would count. So again, for low or limited data, it's either those 2 data points or the category 2, which is assessment requiring an independent historian. And then moderate, 204.214, moderate data, we have 3 categories here, and you just have to meet one of the 3 categories. Category is a little different though. Category 1 for moderate combines 1 and 2 for low. Okay, so let me explain that. Category 1 for moderate is review of external notes, each source, review of results of each unique test, ordering of each unique test, and assessment requiring an independent historian. So they brought the historian into category 1 for this. And in order to meet the data in category 1 to be moderate, you need 3 things here. So that might be 1 external note, 1 lab test, and history from somebody else. That's 3 things. So 3 credits there, so to speak. Or category 2 is independent interpretation of tests. So you are reviewing a test that someone else has already built for, and you are actually doing your own interpretation. So again, with x-rays, that's probably the best example. The patient brings x-rays they've had done somewhere else. You don't just read the radiologist report, you look at those images yourself. So you would need to say, independent review of images shows, whatever that is. It's got to be clear that you looked at the image or you looked at the test itself and not just read someone else's report. And then category 3 is discussion of management or test interpretation. So that's discussion with another provider. External is what this says, but they have clarified that it's either outside your practice or it could be inside your practice if it's a different specialty or a different type of provider. So if you are the physician and you discuss with the speech therapist, or you discussed with the physical therapist, or you discuss with the audiologist, or you discuss with somebody else, either in your practice if it's a different specialty or outside of your practice. And they say you can't do it with the same specialty in your practice because that's what it means to be partners, and they're not gonna credit that there. So those are your 3 categories. And again, for moderate, it's just one of those 3. So if you independently review a test and you document it that way, that's moderate data. You don't have to have any of the other things. If you discuss management of that patient with somebody else, that you've got that moderate. Now category extensive for 5, excuse me, not category, level 5 for 99205, 99215 high is extensive data. Same categories we had for moderate, but you have to have 2 out of the 3. So to meet that high data, maybe you have 3, maybe you've got history from somebody and you've got 2 different tests you looked at. That's 3 credits, that's category 1. And then maybe you talk to somebody else about managing that patient. That's category 3. So you have 2 different categories to meet the high, 1 category to meet the moderate. Okay, hopefully that's clear there. So I'm going to pause just a second because to me that was the one that had the most moving parts there, and there might be a little more confusion on that. So I'm going to pause just a second, Randy Ann, and see if we've got a question.
Okay, we do have a question. If
Okay.
a provider orders an A1C as a point of care test in the office on the same data service, can you get 2 unique tests for category 1 for ordering and review?
No, you get credit for a test once, and you don't get credit at all if you're billing for it. Okay.
Okay, that's all there is right now.
Okay. And then the next element is the risk. And so this is the risk of complications and morbidity or mortality of either diagnostic studies or management options. Now, this looks similar to what we have right now, but the AMA was very intentional about something. When I first looked at this chart a year ago, and I'm like, they left out examples. But I came at the AMA symposium a couple of weeks ago, they said that was intentional. We intentionally did not put examples in this table, unlike the current table, because we felt like the examples were constraining, meaning that they might have an example and everybody would stick with that, but they really wanted it to be the clinician's assessment of the risk based on the patient context. So, for example, right now, over-the-counter medication is low risk, but they said, no. On some patient contexts, it might not be low risk. Let's say a patient is on a blood thinner, but they're also advised to take aspirin. Aspirin is normally low risk, but not for that patient. A patient who has problems with their GI, they've had a previous ulcer or they've had a GI bleed, but then now they've got some problems with arthritis. Well, normally we would try to avoid NSAIDs or Aleve or Advil, but we're taking that risk and saying, yeah, go ahead and take them, but that becomes moderate risk. It's not just low. So they purposely did not put a lot of examples here. So again, it's the physician's judgment of the risk. A couple of things they did change and they did clarify, and again, a lot of this is in that 16-page document I referred to. So first of all, a couple of changes. First of all, in the older table, what we're using now, it says decision for surgery. So patients having surgery. This says decision regarding surgery. So anytime we're having that discussion with the patient about surgery, even if they ultimately do not have surgery, it counts as the risk because you've had that discussion regarding or the decision regarding surgery. Also, identified patient or procedure risk factors. The current table just says identified risk factors. And so there's always been the question, is that patient risk factors or procedure risk factors? So the AMA says it's both. The deal is they have to be identified. So that decision regarding surgery with identified risk factors. A couple of other things to point out. In that moderate box, examples only, that first one is prescription drug management. And I've been doing physician auditing for over 20 years, and we've always had this disagreement, where some people would say, well, antibiotics don't count. It's just amoxicillin. AMA said, oh, no, any prescription counts. The other thing that the AMA was clear about is that this does not require changing a medication, a new prescription, or stopping a medication. You don't have to do anything to that medication regimen. You're just recognizing that they're on it, they're choosing to continue it. It could even be something that you didn't prescribe, but it's included in your decision making, and you recognize that, hey, they're on this medicine from another doctor, it affects my care. That's prescription drug management. So very, very different understanding than maybe some people had about that. So basically, you put them on a med, you've got moderate level risk there. I talked about the decision. That last bullet in this box, I want to come back to in a minute, give you some more information on. Diagnosis or treatment significantly limited by social determinants of health. I'm going to come back to that in a minute. I think we need to talk about that a little bit more. Under 205-215 high, you have, again, examples only. You've got decision regarding surgery with identified risk factors. Decision regarding hospitalization. Again, regarding. If that patient is sick enough to consider hospitalization, even if you decide not to, that's high risk. The other point there is, and I've given you the definition here because I've had lots of questions about, what is drug therapy requiring intensive monitoring for toxicity? So first of all, it's not monitoring therapy for effectiveness or how well that patient's doing. It's monitoring for side effects and for problems there. They also defined intensive monitoring is not less than quarterly, so at least every 3 months, and the monitoring has to be by lab, by physiologic test, or by imaging. Monitoring by history does not qualify. And that's just the way the AMA wrote the rules there. Also, that monitoring has to affect what you're doing today. Okay. So that's the risk. I'm going to talk about those social determinants of health, and then we'll start in some examples, and we'll see if we've got any questions. Okay. So first of all, that social determinants of health. Remember, that's one of the potential supporters of moderate risk and a level 4 visit. So these are diagnosis codes that we've had for, 4 or 5 years. They're not what you're treating. There are circumstances around that patient that may affect what you're treating. So they're socioeconomic or psychosocial, that kind of thing. Now, the way the coding rules are written, we can assign the diagnosis code for this based on the history as long as the physician signs off on that note. But in order for it to support for a visit, so diagnosis code's one thing, supporting the visit, the physician or provider has to say how that problem affects his care, okay? So this is just an example of some of them. They're in the Z55 through Z65 range in the ICD-10 book. So I'd take a look at that and see. And you may, off the top of your head, think about, oh, this is this patient. Oh, this is this patient. So you may already see that and how it affects your care. So just, again, I just pulled some examples in here. This is not all of them. Inadequate housing, lack of adequate food, safe drinking water, insufficient social insurance, that's one. Problems related to living alone, acculturation difficulty. So that could be language difficulty, and not just needing an interpreter. That could be, gosh, having them understand the treatment. Maybe they have different cultural understandings or cultural mores about medical care that affect what you're doing. So again, the diagnosis code comes from the history. The affecting the level comes from what you said. Just a couple of quick examples. I was doing this for an oncology group the other day, and they asked me a question. Hey, Kim, we have a patient with bed bugs, and it's so bad that we've had to change her chemotherapy regimen because of that situation. Is there a code for that? I'm going to put that under inadequate housing. I use my family as coding examples, and they don't like it, but they're just such good examples. I end up using them. So my nephew had a hernia, and he'd had it for a couple of years. It had been increasingly painful. They encouraged him to have it repaired, but he felt like he couldn't afford the copay. They had a very large copay with his insurance. It ended up becoming strangulated, and it was an emergency surgery. So all that time, when the physician's saying, "Hey, you need this hernia repaired," and he's going, "I can't afford it," that would have been Z5 9.7, insufficient social insurance. I see a lot of charts noting where you're concerned about the patient living alone. They're falling or whatever, then you've got that problems related to living alone. So again, this is not what you're treating, but it could impact what you're treating. So I'm encouraging you to look at these for several reasons. One is the diagnosis code, of course, the level of service, but there also may be potentially quality measures and some other metrics that we could be measuring with these social determinants of health. So just kind of think about that, and those that you may already think about patients that they affect. This is the chart. This is just the same chart we saw a few slides ago, but with a pretty blue arrow showing you that bullet. Diagnosis or treatment significantly limited by social determinants of health. So if you had a patient with a chronic illness with exacerbation and your treatment's limited by social determinants of health, you've got a 4. That's what you need for level 4. Just real quick looking at it, again, looking at the bottom part of this chart, if you've got 2 stable chronic illnesses and prescription drugs, you've got a 4. We no longer have to worry about, did we have a detailed history? Did we have a detailed exam? Do we have this many points here and this many here? It breaks it down in some cases to be that simple. You're going to see a lot of 4s, and I think as we go through some of the examples, you'll see that. But then I want to end up talking about what it takes to jump that to a level 5. Not that I'm pushing you to 5s. That's not my intention at all. But I think you can see as we go through these, a lot of 4s, what does it take to get to a 5? So now, Rhonda, again, before we go through the examples, I'll pause a minute and see if we've got any questions.
No, there are no questions at this time.
Okay, well, let's go through our examples, and then we'll come back and you may have some questions at that point. So again, I tried to pull some primary care, some common things that you might see, different ages of patients. If there's scenarios that you felt I didn't cover when we get to the end, you're welcome to ask me that question, or you're welcome to email me. So we have a 27-year-old male seen in the office for a rash. He thinks he got into some poison ivy while working in his backyard. We gave him a steroid injection. Medrol dose pack was prescribed. We told him to use some over-the-counter Benadryl. We had an expanded problem-focused history and exam. Under the current guidelines, this would be a 99202 or 99213. Remember that offset talked about between new patient and established? Under the 2021 guidelines, it would be a level 3, a 203 or a 213. Well, how did I get there? What kind of medical decision making? Well, this is an acute uncomplicated illness or injury. Again, that's a judgment call. We don't have examples there. So we just have to use some judgment and whatever picture the physician has painted. Well, in my mind, this was bad enough for him to come to the doctor for it and not just use calamine lotion at home. So I don't think I'm going to call it self-limited or minor. He needed some help. So I'm going to call that acute uncomplicated illness. There was no data. And then we have prescription drug management because the steroid injection, the Medrol dose pack, those aren't things you can buy without that prescription. 99204-214. Okay, so I had a 3 and a 2 and a 4. What level do we meet or exceed to support that billing? And in this case, we had a 3, we had a 4, so we would have to bring that down, and overall we would build that level 3. So hopefully that makes sense, that 2 out of the 3 elements there. 23-year-old patient comes in with a complaint of sprained ankle 5 days ago, unable to go to work due to pain with standing. Better now, just needs to return to work. But he's still slightly swollen and bruised. So you go ahead and do an x-ray, normal anatomy, advised to rest, ice, elevate, return to work in 2 days. Here's your work note. Expanded problem-focused history and exam. Current guidelines, it would be a 202 or a 213. Under the 2021 guidelines, again, it would be a 203 or 213. Level 3, again, no difference between new and established for the requirements. How did I get there? So I say we have an acute uncomplicated illness again, and no examples, but that just seems to make sense where that is. Straightforward, 1 test reviewed. Remember, we had to have 2 tests to get to the low data. We had straightforward because we just had the 1. Now, had this x-ray been billed by somebody else, and we personally looked at the images, that would have supported the moderate. but we're going with the assumption here that we're billing this. Again, low risk, no examples given, but yeah, we're telling them to stay off of it a couple more days. I'm going to go with low as the risk. So there's some judgment calls made here. And again, they wanted it based on the physician's clinical assessment of risk and the clinical assessment of complexity there. 12-year-old seen in the office for ADHD and anxiety follow-up. This child is on Adderall and sertraline. They're working with a psychologist every other week. We spent 15 minutes in the visit. We didn't change their current meds. We had a detailed history, detailed exam. Under the current guidelines, this would be a 213 or 214, kind of on that line. 2021, it's a 212 based on time. It's a 214 based on medical decision making. Well, how did I get there? So first of all, the time would support just a 2. But if our decision making supports a higher level, we can build that higher level. How did we get there? 2 stable chronic illnesses. They're related, but it's 2 separate illnesses we're treating. Now, just to remind you, when we're talking about counting the number of problems addressed, it's not the number of diagnosis codes, it's the number of problems. So for example, a patient may have a problem and we're billing symptoms and we may have 4 codes for the symptoms. That's still one problem. Conversely, if we have a patient with diabetes and chronic kidney disease, that's two problems. That's 2 different codes. We've kind of got that. So again, how many problems? Not diagnosis codes, how many problems? We had no data, but we did have prescription drug management 99214. So 2 stable chronic illnesses, prescription drug management, that's a 4. Really no further thought needed for that. 2-year-old seen in the office for fever and a rash. Cough and runny nose for 3 days, not sleeping well, no previous ear infections. They do have an ear infection today. We give them oral antibiotics. Contact dermatitis, we give some over-the-counter hydrocortisone. Detailed history, detailed exam. In the current guidelines, it's a 213, 214. 2021, it'd be 212 based on time, but remember, we don't have to use time. It will be a 213, 214 on decision making. Now, how'd I get there? And what's that decision and what's that judgment call? So is it a low or is it a moderate? Are we going to call this an acute uncomplicated illness? Or are we going to call this an acute illness with systemic symptom? Now, again, based on that AMA guidance that even if they have systemic symptoms, but it's in a minor illness, that's when you're going to fall to the acute uncomplicated in the level 3. And I think that's where I'd go with this, 99213. No data, it is prescription drug management, but I think the decision hinges on, are we going to call this acute uncomplicated? And I think that's where this one goes. 17-year-old is seen in the office for evaluation of an eating disorder. She is avoiding and restricting her eating. Her vitals are normal, but her weight is down 15 pounds. She's seeing a psychologist weekly, otherwise in normal limits. Labs are sent out and won't be back till the next day. 35 minutes in the visit. She's scheduled to come back for her next check in 2 weeks. So this is a 4. I think this is very easily a 4. You know, is there any other option there? So detailed history, detailed exam. Under the current guidelines, it's a 99214. 2021, it's a 214 based either time or decision making. So again, either one. Chronic illness with exacerbation would be a 4. Is it low or moderate data? Because just labs sent out, I need to know. Is it 2 labs? It's a 213. Is it 3 or more labs? It's a 214. And I can probably go somewhere else in that record and see it, but it would just be clear if it was in this office note. And do we go with moderate risk? So there's some questions here. There's some things that could possibly push this to a 5. And again, that's not my intention to say, hey, let's get the highest levels. We just want to quantify the work. We want to understand. So a couple of things I think aren't clear. Could this be severe exacerbation? Could this be high risk? So her weight's down 15 pounds, but how long? Since last checked, but when was that? Was that 6 months ago? Was that 2 weeks ago? That's a big difference there. And then what weight did she start at? What's her BMI? What is she severely underweight? Just some information that wasn't clear in this that might potentially support that 5. Did we talk to the psychologist? Did we review the psychologist's records? Any of those things could have supported potentially the higher level of service. And again, I'm not just trying to get to a 5. I just think there's untold story here. And again, this is the entire note. We did not have, we had the history and the exam, but we didn't have that assessment and that plan fleshed out there. So there was some information that's maybe missing. 5-year-old seen in the office for sore throat and fever. Rapid test for strep, for COVID is negative, excuse me. Rapid test for strep is positive. Antibiotics are prescribed. Physicians in the room 15 minutes, both before and after testing. Patient was in the room for 25 minutes. detailed history, detailed exam, it's a level 4 either way. Well, Kim, wait a minute. You had a fever a couple of slides ago, but you said that was a 3. What makes this one different? Again, it comes down to that acute illness with systemic symptoms. Why am I judging this one different? And you may disagree with me, and we could have that discussion. I think that the COVID world makes everything a little different. I think, again, if we're trying to quantify the physician's cognitive work, I think we have to recognize that the COVID world makes it different. The fact that we did the COVID test, and also I have some dear friends who are physicians, and one of them this week on her Facebook page, she's an emergency room physician. She just vented and she said, I don't care if your COVID test was negative. You're sick, stay home. Because we have, some of those, false negatives, and we have just a different situation. That's why this one I would codify. I think there's more counseling going on. I think there's more going on with this than was going on with the child with an ear infection a couple months ago. So again, you may disagree with me. That's just my opinion based on the whole scenario here. Okay, I'm going to run quickly through the rest of the slides, the examples, so I can wind things up and have a minute or two for questions. A patient previously diagnosed with asthma, acute exacerbation. The difference here is it's severe. Severe exacerbation is that complexity, and the physician needs to paint that picture. And then you want to admit the patient, but they decline. And they may decline for insurance reasons. They may decline for family reasons. They just can't leave the family at home. Maybe they're declining for the COVID protocols. They just don't want to do that. Whatever reason, your risk is based on what you recommend, even if the patient declines. So there's a few more examples. I'm going to just go through these, leave these with you. If you look at these and you have further questions, please, absolutely, you're welcome to email me. And of course, I'll share that answer with Rhonda Ann. A couple points here I already mentioned. Be careful with the stable. Is it really stable? If someone's not at treatment goal, it's not stable. So making the leap to 205, 215, it's either the time, or it's that severe exacerbation, or it's that tremendous amount of data, it's that high risk. And tremendous amount of data, that sounds like a whole lot, but the high data could be as simple as independent interpretation of tests and discussion of management with somebody else, or review of 3 tests and discussion with somebody else, or review of 3 tests or 2 tests and independent historian, and independent interpretation. So you could get a level 5 with that data, but again, you would probably also have the severe exacerbation and the high risk. So just to finish getting ready, when I first started doing this, we had 6 months to get ready. Now we've got, 2.5 weeks? Look at your documentation now and think about what's different. Am I telling the complete story? You're still going to do the history and exam, but am I giving everything I need to in the assessment? Make sure that we're documenting the thought process and not just plopping a diagnosis in there. If you're considering coding by time, how are you going to measure that time? How are you going to make sure you catch all of that? Again, do that medically necessary history and exam, whatever's medically appropriate, because you're still going to do that for other reasons, not for coding, or for other reasons. And then look at those social determinants of health. I really believe they could make a difference in your diagnosis coding, possibly your level of service, but I think there's other areas that they may have an impact with. And then again, remember, nothing is changing for your other sites of service, just office visit codes where you assign those codes. There's the 2 resources I mentioned. That first one is the grid. The second one is that 16-page document that explains the grid. And then I'm happy to take further questions. I know we've just got a couple of minutes. I'm happy to stay on a few minutes extra. And then, of course, you have my email and my phone. I'm on Central Time, but I do better answering by email than I do phone, just because time differences and work early. But I'm happy to answer any questions at this point.
Okay, I have a few questions for you.
Okay.
If we are performing a preventative visit along with an office visit, does that change the coding?
In terms of being able to bill a separate visit, those rules are the same. What changed is how you determine that separate office visit. So it's a great question, because you're right now, if you're doing a preventive medicine visit and that visit includes an exam, you couldn't count your exam towards your level of service. Well, now you don't have to worry about that. So it's just going to be based on your decision making. So potentially you may have higher levels of that additional visit than you did before. But no, in terms of determining your level of office visit, it doesn't matter what else you're billing that day. You'll follow whatever those rules are. So it's not the level of visit, it's just whether or not you could bill a separate visit.
Okay. How specifically do we need to document time?
We're waiting to hear from CMS on if they're going to have anything more specific, and we may have something from your particular Medicare contractor. They may come out with something. Right now, we don't have anything, and that's why I kind of gave my opinion is that total time would probably be appropriate if you're talking about a lower level. If you're talking about higher levels, then I would expect to see some more detail. I don't think we need to print out that list of all the activities and go 2 minutes here, 4 minutes here, 6 minutes here. I just think that's onerous, and I don't think that's the intent. So I would just, if I have a longer time level, I would say, 45 total minutes spent, 30 minutes of which was face-to-face with the patient, 20 minutes spent reviewing records, whatever that is, but just briefly. Now, if you have a very long time, then I would expect to see some more detail about what that time involved.
Okay. What about procedures and modifier 25? How is that changing?
Yep, it's not changing. So the definition of modifier 25 is not changed. Whether or not you can bill a separate visit with a procedure, that's not changed. What has changed is what level of service is going to be supported. So just like the preventive medicine we were talking a minute ago. So if your documentation supported a separate office visit before, it supports a separate office visit now. It's just determining what level is going to be appropriate there. And you'll use this new grid to determine that, as opposed to your history exam and decision making before.
Okay, well, thank you, Kim, for the presentation today. It was just awesome. I also want to thank Eric for his tech support. I have put a link to a survey in the chat box. It would be awesome if you could take a minute to complete that survey, everyone. Also, as a reminder, the Oregon Office of Rural Health will host a webinar Q&A on Friday titled RHC Survey During COVID-19. It's a Q&A with Janice McDowell, the state surveyor. She will answer questions on the new COVID-19 focused infection prevention survey. Please email me if you have questions there. Thank you, everyone, for attending. Have a good afternoon. And Kim, you were awesome.
Thank you. Y'all have a great day.
Goodbye, everyone.